Good morning and welcome to Grand Rounds. This morning we are happy to welcome Dr. Judith Sim-Sendon. Dr. Sim-Sendon graduated from the University of Florida College of Medicine in Gainesville, where she also completed her residency in obstetrics and gynecology. She's an associate professor at the University of Central Florida College of Medicine, and she's been a part of Arnold Palmer Hospital Pediatric and Adolescent Gynecology Specialty since 2010. This morning, Dr. Sim-Sendon is going to speak to us on the management of heavy menstrual bleeding in adolescent girls. Please welcome Dr. Judith Sim-Sendon.
Thank you all for having me here. I am so glad to be able to give this presentation to you all. In fact, when I was asked to give Grand Rounds, because we get so many of these patients admitted to the PED service and admitted to the, my voice carries so much, yeah, now it's on. Because we get so many admitted to the PED service, we get so many of these coming into the emergency room, I really wanted to give you a presentation that would be really useful. Also, there are guidelines that I sent to Nancy for management of heavy menstrual bleeding. I also gave a copy to Dr. Tokarski this morning that I want everybody to have, put on your phone, store it. It's got all the algorithms for how to manage these girls when they come into the emergency room. And any questions you have about why we do what we do or what the logic is of anything I present today, please don't hesitate to ask. Anybody who's rotated through my clinic knows I am hardly shy. All right? Right? So I usually don't read objective slides, but essentially what I'm going to do is go over briefly normal menarche because I just can't help myself. Also, anybody who's come through my clinic knows that we go over the HPO axis to start from scratch every time. I'll talk about the differential diagnosis of heavy menstrual bleeding and dysfunctional bleeding in adolescents, and talk about the most common things you all see, which are the bleeding disorders presenting at menarche. All right. So let's start at the very beginning. And let me see. Okay, here we go. All right, here's the HCG level. This is weeks of pregnancy. This is this little girl fetus in here, a baby, and then all the way up through puberty. Okay? So here are the number of oogonia she is born with. They're going through mitosis up to around 20 weeks. And then, ladies, it's all downhill from 20 weeks gestation. That's it. All our mitoses are done. It's just meiosis after that. Here's the FSH level starting to rise, and that's because the GnRH neurons have migrated in the from the olfactory placode to the arcuate nucleus. What's it called if they don't migrate and if they're not formed? This is one of these in-service exams. Kalman's, right? When you don't make it. These migrate, and then the hypothalamic axis wakes up the gonadotropins, and you start making FSH and LH. Then they start to fall. Anybody know why? What's the feedback coming from that makes this FSH and LH fall? It's coming from where? Where are the hormones coming from? It's negative feedback of estrogen and progesterone. Where are those hormones coming from in this fetus? Mother. That's right. They're coming from the placenta. You're making lots of progesterone and estrogen in the placenta, right? Negative feedback. And then, voila, the baby's born, and then it's your problem. Okay? We're done in OB. And then you see this rise in FSH and LH, and that's because you've removed the placenta. You've separated the baby from the placenta again. So you get this rise in FSH and LH, and you get this little rise up here in, actually in estrogen production. So what do you guys see when that happens? Yeah, exactly. For those in the cheap seats, neonatal gynecomastia and withdrawal bleeding in the first few days over here as well. And then everything shuts down. Why? We don't know. We still haven't found the magic thing that shuts everything down. And then it all wakes up again in puberty. Okay? What is it that wakes everything back up? Well, we know that there are a whole lot of multiple factors in there. There's body weight, there's stress levels, there's the presence of leptin. We know that all of a sudden, though, it does start to wake up. And it starts initially with little tiny bits of LH at night as your precursors, and then you to help start to make some androgens to then form estrogens. And then your estrogens start to form with FSH stimulation. I'm not going to do a whole puberty lecture. You'll be probably relieved. But the main thing I want you to get out of this is that it starts with estrogen and it starts with breast development. And then it progresses in a very consistent way to menarche. And there's about 2 years between the onset of breast development and the beginning of menarche, and that's consistent. And the way to think about it is inside that little girl's pelvis, the uterus, prepubertally, is super tiny. In fact, there have been plenty of girls who've been told they don't have a uterus before puberty, then all of a sudden, voila, she's got one as soon as she's got estrogen on board. So you have to know that it's the same size as essentially the non-existent breast before puberty. And then you get breast development, and then it takes about 2 years to grow a uterus in the presence of estrogen that's big enough to actually be able to have periods. Why is that so important? If you've got a 10-year-old or an 11-year-old that comes into the emergency room with vaginal bleeding, look at her breasts. Make sure that she actually has breast development, because if she has no breast development and she's got vaginal bleeding, you have a problem that is not a menstrual disorder. You have to think of trauma. You have to think of tumors. You have to think of other things. Okay. Again, everybody knows I love to draw this out. This is my really lame PowerPoint add-ins that I tried to do because I didn't have a board to draw on in here. So here's your HPO axis, and here's your hypothalamus stimulating your pituitary through GnRH, and your pituitary makes FSH and stimulates those little follicles in the ovary. Follicular cysts in the ovary are 100% normal, and you all see these reports on ultrasound. She's got a 2-centimeter dominant follicle. Can you see follicles in the ovary before onset of periods? Absolutely. That's where her boobs are coming from. All right? That's her estrogen production. So if you see small little follicles in the ovary in pre-menarchal girls, that's pretty normal. So here's your estrogen level rising with the FSH production. Here's a uterus that's finally big enough to be able to accommodate this. In an adult, the estrogen causes the endometrium to grow. The estrogen level rises, triggers an LH surge that causes ovulation, production of a corpus luteum cyst, production of progesterone. And then in the absence of pregnancy, in the absence of HCG, everything falls. That's my high-tech graphic. I was super proud of that. And then you get a period. And then it starts all over again. Estrogen rises, and you make another lining. That's what happens in adults. That's an ovulatory menstrual cycle. All right, here's your adolescent. In early adolescence, the cycles aren't ovulatory. The FSH goes up, the estrogen level rises, she builds up a lining, and then her brain goes, I'm tired. I don't feel like ovulating yet. Essentially, she has an immature HPO axis, so the estrogen level then falls. She gets some bleeding, and then it starts all over again. And the first couple years after a girl starts her cycles, most of the cycles are actually anovulatory, and she's actually only having estrogen withdrawal bleeding. How can you tell when a girl starts ovulating? What happens? What happens? What does she get? Cramps. Thank you. She gets dysmenorrhea. All right. Because it's progesterone withdrawal that causes the pain. So these girls coming into the emergency room with this anovulatory bleeding, they've been bleeding like stuck pigs, but they're not in pain. And it's because they aren't having progesterone withdrawal bleeds often. So in the United States, about 98% of the girls will have a period before the age of 15. In the developed world, the average age of menarche, so onset of periods, has stayed relatively stable for the last 50 years. Breast development has started to get earlier and earlier with the onset of more and more obese girls. But menstrues have actually stayed pretty stable. The average age is about 12.2 months for African American and Hispanic girls. And yes, I see plenty of girls in my clinic who have periods at age 10 and 11. And they're about 12 and a half for Caucasian girls. When do we care if they're not having periods? If they've had breast development for 3 years and they haven't had a period yet, something's wrong. Either puberty started then stopped, or they've got PCOS and they're not ovulating, something's up. If you haven't had a period by age 14 and you've got all these other signs of PCOS, or if you've got no signs of periods at all, by the time you're 15, that's outside those 2 standard deviations and girl needs a workup. So most of us know, because cycles are anovulatory, that they can be a little irregular in those first few years. What's surprising is most of them are pretty regular, with a mean of 21 to 42 days. So most of them will have a flow length of about 2 to 5, 6, 7 days. The interval between when they start their period and when they have regular cycles is only about a year. Their average amount of tampons and pads most girls use are about 3 to 6, although you will have girls who can't stand the sight of blood, and they're going through 15 pads a day, making her mother broke because she just can't stand blood. When do we worry that things aren't normal? If those cycle lengths are really persistently less than 21 days or greater than 45 days, if they're initially regular and they become irregular, doesn't that make sense? If the flow lasts more than 7 days. I have to tell you that about twice a week, we get a girl in my clinic who's been bleeding for 4, 5, and 6 weeks straight. This is not normal. This is not just, oh, she's not ovulating the first couple years. It's not okay to bleed more than 7 days all the time. I mean, that's not good. And if she's changing a pad every 1 to 2 hours, that's not okay either. We really need to work these girls up. Also, if they feel bad, if they come in and they tell you, I'm really tired, I don't feel well, I'm bleeding all the time, it's not normal. So you'll be happy to know that we've gotten rid of in OBGYN the words menorrhagia, metrorrhagia. We just call it heavy menstrual bleeding, thank God. We don't have to worry about all the fancy words. Okay? So heavy menstrual bleeding is bleeding for more than 7 days or loss of more than 80 cc's per menstrual cycle. Now, I don't know about you, but I've not ever asked a patient, so did you bleed 80 cc's last month? So how do we tell if they're bleeding 80 cc's or more every month? So if their clots are bigger than a quarter, okay? If they've got low ferritin levels, which they'll have oftentimes before they actually have low hemoglobin levels, and if they're changing a tampon or pad every hour and bleeding through, and are you bleeding through your sheets? Are you bleeding through your clothes? Are you having accidents at school? That's a problem. There are these pictorial bleeding assessment calendars, and sometimes for my special needs girls, these can be really helpful. I don't think you necessarily have to document this in clinic, but it can be really nice if you've got those patients or those families that just don't get what you're trying to ask. Their mothers are bringing them in for heavy bleeding, but they've never actually seen the girls' pads. Okay? Now, sometimes they've seen them too much. It's a little weird. So how do we classify things in the adult world? And this is the FIGO, which is the International OBGYN Society, classification of abnormal bleeding for adult reproductive age women. And they classify them into either structural or non-structural causes. Structural are things like polyps, endometriosis and adenomyosis, fibroids, or cancers. And then there's non-structural, which are coagulopathies, ovulatory dysfunction, endometrial problems, and we'll talk about that in terms of teens, iatrogenic, something I did, probably not something you guys did, or then not yet classified. This is okay for adults, but I like to break it down more into what do you all need to be worried about when you see these girls, because to be honest, malignancy is very, very unlikely in your age group that you're seeing. So are polyps. What are you likely to see? Overwhelmingly, the most likely reason why you're seeing these girls is that they're not ovulating and because they have an immature HPO axis. And as I like to say, sometimes y'all don't listen to your mamas, sometimes your brain doesn't listen to you, and they're not ovulating regularly. We always have to consider pregnancy, infections, and I'll talk a little bit more about chlamydia, but chlamydia causes a lot of weird abnormal bleeding. endometriosis, which is underdiagnosed in adolescents, and trauma. These are your most common gynecologic causes of abnormal bleeding in teens, and I'll go into them in a little more detail. And then, of course, the non-gynecologic disorders are your coagulation disorders, and those it's very important to understand because those present at menarche. And some and iatrogenic causes, birth control, or Coumadin, or chemotherapy. So if you look at causes of heavy menstrual bleeding by age, again, what you're really looking at are these adolescent anovulation, bleeding disorders, and then anticoagulation therapy. Aren't you glad you can forget about all of these? No. So this is the most important one. If you don't take away anything else from this lecture, understanding this is so key. So what happens is the hypothalamic pituitary axis starts pumping out FSH, follicle stimulating hormone, and the ovary starts making estrogen. Now, usually that would then cause a negative feedback of the estrogen to the FSH. But sometimes the brain doesn't listen. So it keeps making FSH in the setting of estrogen. And what happens is you get this thickened, dilated spiral arterioles. And it gets thicker and thicker, and it develops a lack of supporting structures. What happens then is you get this random, prolonged, irregular, asynchronous shedding of the endometrium. So bits are coming out here, bits are coming out there, and it's this chronic weeks of bleeding, all different variations, sometimes a little bit, sometimes a little more, but it's random and it's asynchronous. Until finally the brain goes, silly me, I was supposed to drop that FSH. Then it drops, and you've got this really thickened endometrium that comes out all at once. And these are the girls that then come in with this super heavy, prolonged bleeding. Those are the ones that we're admitting to the peds hospital service from the emergency room who've had this acute, heavier bleed. Oftentimes, these occur in these anovulatory girls in the setting of really prolonged, irregular, light bleeding, and then boom, very heavy bleeding. Or every now and then you'll get girls who will have had 3 to 4 months of not having had any bleeding at all, and then voila, they shed this massive endometrium. Another way to look at it is kind of like this. There's a little bit of estrogen variation, but essentially spotting, random bleeding, and then voila, a heavy bleed all at once. Any questions about anovulatory bleeding? We'll talk about how to treat all this, because the treatments are very similar. Okay, that's anovulatory bleeding. And actually, most people who know me know I really care a lot about this. What am I going to ask about when they come in with anovulatory bleeding? Stress, right? I'm a huge girl into that heads interview. Almost always, when these girls have these early onset of menses and then these really irregular bleedings, there is some kind of drama in that house, and I want to know what it is. Either her parents are getting divorced, or she's getting bullied at school, or there's been something that's happened in her life that have made things rough. Grandmother's at the house who's dying. I'm going to figure out what it is, because until we address that psychosocial stressor that really may be making her have those anovulatory cycles, we're not fixing the underlying problem. And sometimes this anovulatory bleeding is really the symptom of all the drama that's been happening at home. So I want to know what's going on in her life. In fact, probably some of you who've called me about these girls, you've admitted have heard me say, okay, what's happening in her life? I want to know. Because it's that underlying chaos that often contributes to this. Okay, moving on to endometriosis. Most people still think that endometriosis is a disorder affecting 30-year-olds or women with infertility. Well, actually, we now know that the symptoms and the disease present much earlier, sometimes as early as within 1 to 2 years of menarche. And there's a big delay, oftentimes of up to 10 years, between when a girl presents with symptoms and when she's actually diagnosed. And it's one of those disorders that unless you think about it, you're not going to diagnose it. Many girls have moms who say, well, my periods were awful too. Suck it up, child. Take some ibuprofen, go to class. But when girls are really missing school, not responding to ibuprofen, not getting better when you've put them on birth control pills, 75% up to have endometriosis when we operate on them. So it's something to think about. And you all went to med school. You all know that once that endometriosis is growth of the lining when it's not growing inside the uterus and it's growing outside the pelvis. So it can be counterintuitive to understand why somebody with endometriosis has abnormal bleeding. It's easy to picture why they have pain because we all picture that inflammation. Okay, they're bleeding inside the pelvis. They've got these peritoneal implants. That's what's causing them to bleed. Well, in reality, in girls who have endometriosis, it's not just the endometrial implants that are abnormal, it's the endometrium itself. And it may go all the way back to when they were a fetus, and we have like the toll-like receptor 4 pathways of inflammation that may have developed as a fetus that we now understand affects abnormally the endometrial and endometrial tissue. So I'm not going to torture you with the lecture on endometriosis. What do you need to understand about why endometriosis causes abnormal bleeding? In normal endometrium, there's not aromatase. What does aromatase help make? Estradiol, right? So usually we think of the ovaries as the source of estradiol, as the source of aromatase. Normally, in patients who have endometriosis, both their endometrium and the endometrial implants make its own estrogen. And it becomes like this little nasty autocrine hormonal system that ignores the signals coming from the brain. It also ignores sometimes the extra hormones that we give in terms of birth control pills to try and control it. So they have this perpetuated, unopposed estrogen-like effect that happens when you have endometriosis, and that's why they bleed abnormally. It's because the endometrium is not normal, and the endometriosis tissue itself is not normal. And these are girls that we really need to address a little bit more aggressively. I have a 16-year-old I've operated on 4 times with recurrent endometriosis, presented initially at age 13. I just operated on another 13-year-old with endometriosis. We are seeing this at young and young ages. So when should you think about it? Severe pain and bleeding. I mentioned that anovulatory bleeding is usually painless, right? So if they're having severe pain with bleeding, you want to think, could they have endometriosis even this young? And the answer is yes. What predisposes you also to have endometriosis at a young age? What should you think about too? A Mullerian anomaly. So if you have an abnormal uterus and you have an obstruction there, say a duplicated uterus with backflow of blood into the pelvis with an obstruction, that will cause endometriosis either. That's why when they have pain and abnormal bleeding, we want an ultrasound. I'm going to get back to the whole workup, but I kind of want to explain the logic as we go through these things. Chlamydia. Oh, we have chlamydia down here in the South. We have lots of chlamydia down here in the South. We have more chlamydia in the South than we have just about anywhere else in the country. Woohoo! And about 70% of the cases progress from the lower genital tract to the upper genital tract and cause inflammation in the endometrium and cause bleeding. If you have girls who've done great with IUDs, with their Nexplanons, with their birth control pills, and all of a sudden they're having weird random bleeding, girlfriend may have chlamydia. Y'all know how to check for that. You can just send the urine right from the emergency room. All right. I am not a hematologist, oncologist. I'm not that smart. But I do know a few things about platelet aggregation as it applies to gynecology. This is not going to be a bleeding disorders lecture. But the other key thing to think about in adolescents who present with heavy bleeding that you have to rule out is a bleeding disorder. So to do that, you have to understand a little bit about platelet aggregation, most importantly about von Willebrand's factor, which forms the bridge between the platelet wall and the subendothelial space and help it stick. Yes, I know these slides are in Spanish, but it's the prettiest picture I've ever found, and so it's in Spanish. But really, if you can't figure out that liberation of ADP is liberation of ADP, you got this, right? Thromboxano is thromboxane. Okay? No problem. It's a beautiful picture. I'm not going to mess with it. So there's also the glycoprotein 1b95 complex that binds the von Willebrand's factor on the subendothelial side, and that's important for the high flow clot formation. And the glycoprotein 2b3a, which forms the fibrinogen complex and links the platelets together. All of these things have to work. Why? Because when that endometrium is shed, you've exposed the spiral arterioles. And if you can't clot in your spiral arterioles, you're going to have heavy, persistent bleeding. Most of you all have spent a lot of time in labor and delivery because you have to deliver the babies, the C-sections and everything else. I assume that peds residents are still there for those. We're always worried in labor and delivery about atony, right? After a woman has a baby, does the uterus clamp back down? That's not a big factor in terms of stopping bleeding for menstrual cycles. It's a big deal when a woman has a baby, but it's not a big deal for menstrual bleeding. So the things that control menstrual bleeding are really the endometrium being able to heal itself over and seal up, and the platelets and the function being okay so that they stop bleeding as the blood is flowing out of the spiral arterioles. Those are the two main things we have to worry about. So as you all know, von Willebrand's is the most common inherited bleeding disorder. It's in about 1.3% of the population. The most common kind is type 1. It's autosomal dominant. And what you're seeing is a mild to moderate decrease in von Willebrand's factor and factor 8. Type 2 is autosomal recessive, and it's structurally abnormal von Willebrand's factor. And type 3 is really rare, and it's autosomal recessive, and you're missing these complexes, and this has usually been diagnosed well before they have a period. Other rare disorders that are assessed by platelet function tests are Bernard-Soulier and Glanzmann's. When we're diagnosing these, I'm usually involving the help of my hem-onc colleagues. Also, I'm really excited to announce that we're going to be running a bleeding disorders clinic with the hematologist starting in January for these girls. So what are the red flags? This is by the CDC. There's a big push for this. If they have little wounds that keep bleeding and bleeding, a girl cuts herself when she shaves and it doesn't stop bleeding. Bleeding after surgical procedures, bleeding when nose bleeds is the big one that I ask in peds, or gum bleeding, or prolonged bleeding after dental extractions. Anemia requiring blood transfusion. If a child has been admitted for heavy menstrual bleeding and it required a blood transfusion, she has a very high likelihood of having a bleeding disorder, and you have to rule those things out. Passing clots bigger than an inch, or a blood relative with a bleeding disorder, or a mom who has very, very heavy menstrual periods. Many times these women have gone their whole life and not been diagnosed. All right. As your mentors have always taught, almost everything you need to know about making this diagnosis is going to be in your patient history. And I have this on the guide that we are sending out to everybody. First of all, we want a full menstrual history. You want a full menstrual history in these girls. How old were they when they started bleeding? How frequent are they? How long? How heavy? How many pads? How many tampons? All of that we want to know. Is she having symptoms of anemia? All right. Is she dizzy? Is she lightheaded? Is she tired all the time? Nosebleeds, gum bleeds, easy bruising, family history of bleeding disorders. Any use of hormonal contraceptives. Sexual activity. You all know you're not going to ask this in front of anybody's mother or father or grandmother. Please, even if they say they don't speak English, they understand sex. Okay? You kick them out. You have to ask. Everybody knows that word. I don't care what language you speak. Okay? In their past medical history, I want you to ask if they have migraines with aura. Why? You can't use OCs. I don't want to give them estrogen if they've got migraines with aura. I like my patients. I don't want to give them a stroke. Okay? You want to ask about history of DVT or PE, liver disease, kidney disease, or gallbladder disease, and use of seizure medicines, especially. Histories of malignancies in the past. Have they had pelvic radiation therapy that might spark more interest, and could they have something happening on their uterus that's a tumor? And then we need that psychosocial history, especially histories of depression, cutting, and again, I never ask that in front of patients' moms either. Girls are really good at putting on that face that says, yeah, everything's perfect, it's all fine, until you really ask the details. Basic physical exam. I want orthostatics. We all need to remember to do these. And what's most sensitive, blood pressure or pulse?
Blood pressure.
Pulse. Pulse. Pulse is more sensitive if you're going to check for orthostatics, right? So pulse. Look for acanthosis, acne, hirsutism, signs of PCOS. I want you to look at their skin, pull up their sleeves, look at their tummy, look at their thighs, look for cutting, right? You do not need to do an internal pelvic exam. Did I have the collected side of PEDS relief? Unless she's got a history of laceration or trauma that you suspect, or having severe pain, you suspect something's going on inside of there. That does not have to be your initial thing. Chances are, if she's bleeding out of her vagina, her vagina is open. You're going to get more information from other imaging sources than that. Now, if she's got a history of trauma, obviously you have to look. You want to document Tanner staging, and I think that's pretty clear now because of the importance of breast exam, height and weight. All right? But you can defer the pelvic exam unless she's having a lot of pain. Now, it is helpful if she says she's bleeding all the time and passing big clots. I've asked to see their pads. I've asked to look at their perineum in the emergency room to see how heavy, are they actively bleeding heavily. That is important to know. But you don't have to do an internal exam for that. So lab studies. What do we want? First line is a pregnancy test. I mean, duh. Okay? And then I want a TSH because that can cause irregular bleeding. I want a CBC with platelets because teenage girls can present with ITP as their first sign of, and menarche is the first sign of this, and PT and PTT. You want to check a prothrombin time, a partial thromboplastin time, and again, I need that platelet count. You can check a von Willebrand's antigen in the setting of heavy bleeding, and if it's none, you know you've got a real bleeding disorder there. But doing full platelet function studies and checking factor VIII levels, I think, are really not that helpful in the setting of a very heavy bleed because they're abnormal in response to the bleeding itself. Consider gonorrhea and chlamydia testing if they're sexually active, and if you have any doubt, check gonorrhea and chlamydia and ask forgiveness, not permission. Sometimes you just have to do this. I'm sorry, we just do it on everybody. Every now and then, we come back with some positives and patients who've said, no, I've never had sex. People lie to me sometimes. It happens. It happens. Right? I'll do a little bit of the PCOS workup, but especially hemoglobin A1C if they're in the emergency setting, but a lot of times that can wait. It's really not going to affect your management in the acute setting. And again, if the hemoglobin's really low, less than 10, you want to really make sure that you've got clotting studies. When do I type in cross? You can consider it if the hemoglobin's less than 7. Y'all know how I feel about blood transfusions. Okay. Ultrasound. Who needs an ultrasound? The utility is pretty controversial. In general, if somebody's having anovulatory bleeding, it's really not going to help add that much, except it does give you information about the thickness of the endometrial lining. So you know what you're starting with before you're adding hormones to it. Fibroids are really uncommon in teens. They do occur, but it's rare. Rarely you could find a big ovarian mass producing estrogen. That'd be a granulosa cell tumor. And you can also find a Mullerian anomaly. But is it critical that she has one on admission? It's nice. We love that information. It's what we do, but it's not the most important. So how do we treat? I'm going to make it easy. I'm going to say you really only need to know one birth control pill type. And that's the ones that have second-generation progesterone, Levonorgestrel or Norgestrel. At Arnold Palmer Hospital, there's Overall. Out in the community, it's low Overall, Crescel, or Curvello, and now it's available on the $9 plans at Walmart. I have absolutely no relationship with pharma. Why do I recommend this particular type of pill? Because the progesterone is the strongest on the endometrium in adolescent girls. It works. I have girls brought into my office who are worried you have providers who are worried or mothers who are worried because they're 11, they need to have the lowest amount of hormones possible because they're just little. It's actually the opposite. Is your 11-year-old going to get a DVT? No, it's your 40-year-old mother that's going to get the DVT. The 11-year-old needs a strong enough amount of estrogen. Her uterus hasn't been listening. We need to really get estrogen on there to stabilize it and progesterone to stabilize the endometrium as well. So using just little toquecitos, little touches of hormones, doesn't work in these girls. You got to give them something strong. So if they've just been having that protracted, prolonged bleeding and their hemoglobin's 11, 12, you can start them on low overall or Cresel from the emergency room. And that's what's on that sheet. And then you'll keep it on, and for at least the first 3 weeks, the first withdrawal bleed will be heavy. And you have to tell them that, because they've had that dysfunctional asynchronous shedding for 3 weeks. When it finally comes out, that first bleed is going to be heavy. And their mother's going to say, those pills don't work. The pills are working fine. They stabilize the endometrium. Give it the next cycle and she'll be fine. If the bleeding is heavy, hemoglobin's 8 to 10, but the patient's hemodynamically stable. In general, we'll start the low overall TID for 3 days, then it's not BTID, it's BID for 3 days, and then daily for at least 21 days, and we have to write out daily, not QD. I have to redo that. I usually check a withdrawal bleed, I check a hemoglobin before I'll allow a withdrawal bleed. So if they come in and have a hemoglobin of 8, and I put them on an OC taper, before I let them have a withdrawal bleed, I'm going to make sure their hemoglobin's up to 10 or 11 again before I let that happen. Sometimes girls will have breakthrough bleeding as they wean to BID, from BID to daily, so I'll put them back up to BID. And again, stabilize them until that hemoglobin is okay, then allow a withdrawal bleed, and then put them on just daily, and they usually do fine. So what are some of the common contraindications that we see in girls? Most of our girls don't have uncontrolled hypertension when they're kids. Some may have migraines with aura, and I'll give you some alternatives to use. Known thrombogenic mutations. Under the age of 20, though, even if they had one of these and you didn't know, because their blood vessels are still so pristine, they haven't messed them up yet with McDonald's, they are usually going to tolerate being on birth control pills as well. Complicated valvular heart disease, if they've been in one of Raptulis's patients, we need to think about different ways to manage them. Diabetes with nephropathy, we usually don't see those girls. Certain anticonvulsants make the birth control pills less effective, so you have to increase the dose. And then finally, lamotrigine, I can never say it right, Lamictal. Their levels go down when you use birth control pills so they can have increased seizure activity. If you have a girl on Lamictal that has heavy bleeding, I always call the neurologist because they'll change the dose, they'll up it by about 20% in order to be able to accommodate the OCs. If you can't use estrogen, what can you use? My personal favorite is norethindrone. You may know it as what's in the mini pill. This is not mini pill doses. This is 5 to 10 milligrams daily. And if they come in with heavy bleeding, I'll put them on 10 milligrams daily of norethindrone. And it's a very strong synthetic progesterone that works very well to control the bleeding. You can use also oral Provera, but do not give these girls shots of Depo-Provera. And the reason is what? You can't take it back out. It's there for 12 weeks. It's not good to control the bleeding. I can titrate doses of medroxyprogesterone if it's oral. I can titrate my norethindrone. But Depo-Provera is not good to treat these girls with abnormal bleeding. Now, when do I recommend hospitalization? If they're actively bleeding with their hemoglobin less than 8, If their hemoglobin is 8 and they're walking in, or 7.5, and they've stopped bleeding and they're hemodynamically stable, they don't need to be admitted. But if they're actively bleeding heavily, their hemoglobin is less than 8, or if they're symptomatic, they need to be admitted. Volume expand with fluids. Do not transfuse unless they are really symptomatic, okay? And I don't transfuse for a hemoglobin of 6. I don't transfuse for a hemoglobin of 7. I've sent girls home with a hemoglobin of 4.9. As long as they are not symptomatic and they are not bleeding. Because these girls are young, these girls are healthy. I'm not talking about your chemotherapy patients. I'm not talking about your cancer patients. I'm talking about your average adolescent girl. Her heart's better than anybody in this room. She's going to tolerate a low hemoglobin. Her brain can tolerate it well. You want to give as little blood as possible to these girls. Why? Pardon? Antibodies. I don't want these girls isoimmunized and having hemolytic anemia of the newborn when they have their first kid. It's just not necessary. God knows also what's in all the blood products. If you're going to transfuse 1 unit, then check their symptoms, check their hemoglobin if you want, and reassess. Don't automatically transfuse 2 units. That whole dictum of if you're going to give 1, you may as well give 2, that's like, I mean, if you're going to have 1 plate of ziti, you may as well have 2. I mean, it's just not necessary. Just give the 1 and reach, well, maybe yes for some people, but, but really use this as a very precious resource, but also one that's a little dangerous. And so reassess. Most girls will respond much better than you would anticipate after even only 1 unit of blood. Okay? And again, in general, healthy adolescent girls, they can tolerate a hemoglobin of 5 or 6, and as long as you build back up their iron. Now, we want to not forget iron therapy. And Dr. Eslin has taught me ferrous-gluconate, BID, is the preferred oral. I will tell you that my bias in taking care of adolescents for the last 25 years is they're not great at taking iron therapy. They're not good at taking their meds. So I will humbly request that while they're in the hospital, if you can give them some IV iron and give them a little extra boost before you send them out, I think that it's really good to get the ball rolling. Because girls go, oh, I'm constipated. Oh, it makes me nauseous. Also explain what iron therapy does. I give them the little talk of, do you know that it's iron that carries the oxygen to your brain? And when all those little red blood cells with the little iron molecules are falling out of your vagina, you need to add some more iron. And it's, right? Yeah, I say the V word all the time. I'm a gynecologist. But I think that it's really important to give them that kind of very graphic, oh, I'm replacing all the iron that fell on my pad. Okay. All right. If you're giving hormonal therapy as an inpatient, the only thing that's available on the APH formulary as far as birth control pills is Overall. And Overall is 50 mics of ethinyl estradiol. It is a walloping amount of estrogen. Be kind. Give them some ondansetron. Give them some Zofran when you prescribe this stuff because it can make them nauseous. If they're really bleeding heavily, you can give it up to every 6 hours. If they're really nauseous and they can't tolerate PO, you can also use IV Premarin, 25 milligrams, and you give it every 4 to 6 hours for 4 to 6 doses. It really is great to stop the bleeding about 90% of the time, and then it will switch to birth control pills. It's hemostatic on the endothelial cells, and it increases your circulating factors of 8, 7, and fibrinogen, which is why once they're on these hormones, we don't check bleeding disorders. We have to wait till they're off. So antifibrinolytics. This is another great option, and yes, you can use them with birth control pills in spite of the warning that comes up on the screens when you try to prescribe it. We know that some girls have heavy menstrual bleeding associated with loss of high plasmin levels inside the endometrial cavity. And we know that sometimes this is genetic, although we're not doing endometrial biopsies on adolescent girls to check their plasmin levels. Suffice it to say, though, that antifibrinolytics work, and we use a lot of tranexamic acid for these girls. The dose is 650 milligram tablets. You give 3 times a day. You can only use it for 5 days. Girls get nausea, vomiting for this too. We were really excited when this first came out, thinking, okay, it won't make them puke like birth control pills do, but it too makes them puke. So it also means you're having to dose it 3 times a day, and they're horse pills. The things are big. So girls aren't as big a fan of using tranexamic acid as we thought they would be, but it also works to help stop bleeding. What it does is it inhibits plasmin activity. For my girls with bleeding disorders, we usually maintain them on continuous birth control pills. I also will use IUDs on girls, on Levonorgestrel IUD for girls with bleeding disorders. And I'm not going to go into DDAVP because that's usually the purview of our hematologists. But it stimulates the endogenous release of von Willebrand's factor and factor 7 from storage cells. I'm going to skip this in the name of time, too. I know you have things to do. I do want to talk more about something that I'm very comfortable with, that I do a lot in my clinic, is using IUDs for girls with heavy menstrual bleeding. These are girls who oftentimes who have never been sexually active. If they can use a tampon, I can put in an IUD. And I'm very comfortable doing that. I do a paracervical block. We have local anesthesia. I can talk to the walls. I can certainly talk to the teens. So we just chat all the way through. I let them play on their phone. We always play music. If you look at my playlist, it's Rihanna, Beyonce, Kendrick Lamar. I've got all these people on there. Now my kids think I'm very cool, but it's because I'm always playing music off my phone for IUD insertions. It does not interfere with future fertility. Perfectly fine to use in these girls, and it works because the progesterone thins out the endometrial lining directly, which is really, really effective. I also use it in girls with special needs who can't handle their menstrual hygiene. When it comes to oncology patients, it's different. Although you can use IUDs in girls who are immunosuppressed, we can do better than that. In girls who are getting chemotherapy, and girls who have really low platelet levels as well, they tend to use a GnRH agonist antagonist like Lupron. And this is important for 2 reasons. One, it's been shown to be very effective at turning off that whole HPO axis, helping girls not bleed. It's not good in the setting of acute heavy bleeding, but it's great for girls who may bleed heavily when they are on chemotherapy and have low platelet counts. The other thing that's interesting with Lupron is it may prevent some premature ovarian insufficiency that are caused by those alkylating agents. The data on it is mixed, but anytime I can give a girl who's going through chemotherapy something that may save her ovaries for later, I'm going to do it. And so I use Lupron in these girls, and we start it right away. It is an agonist-antagonist. So initially you may get a little stimulation of FSH and LH and a little bit of bleeding before it completely suppresses the pituitary release. And so it's great, though, for long-term use in these girls, 6 months to a year when they're going through chemotherapy. And I want to leave time for questions. There's my summary up there. You will get, guys, what kind of questions do you all have? I'm sorry, just be up here. I can't stand here. Yes?
For the continuous OCPs that you give to people with bleeding disorders, is there a certain amount of months that you can go without them needing?
If they're not, no, they can, till the cows come home. I mean, they can bleed, it's great. You can stay on continuous OCs forever because the progesterone in the birth control pill is dominant over the estrogen. It thins out the endometrium, and so when they've looked at girls who've been on them for 3 and 6 months to years, you're looking at an endometrium that's 5 millimeters. Usually when I say that, the women in the room are like, sweet, I don't need to have a period. No, you don't need to have a period. You can take continuous OCs.
Do you have trouble writing prescriptions for that?
It's very easy. No, but do I have trouble for the coverage from the pharmacy? Yes, some insurance companies require prior authorization letters, especially the girls with bleeding disorders. Because some of these pills are now available at Walmart for $9, if I send it, Walmart has its problems, but it's got cheap birth control pills. And so because I can get it for $9 a month there, I will sometimes send a prescription there. Most people can afford the $9 if they have to buy out of pocket that extra pack. The other thing is there are extended cycle birth control pills, Seasonique, Seasonal, Quasense, that are 3-month dosing cycles that makes it easier to do that with. Yes?
For those patients that we have coming in with heavy bleeding, do we typically do the OC taper and then talk about doing an IUD, or are we able to kind of...
I usually don't do an IUD in the hospital. I would usually do an OC taper and then get them into clinic. In the setting of acute heavy bleeding, also, they might be more likely to expel the IUD because if they're passing clots, they may pass the IUD out with it. So I usually try to control the bleeding and do the whole workup and then get the IUD in. So no, you don't have to put the IUD in the hospital. Yeah. It's also hard to get coverage for that. It's a problem. Yeah.
Thank you so much for the great talk. I just wanted to make a point on the von Willebrand testing.
Yes.
Because being on the other end,
Right.
getting to make that
Yes.
diagnosis, is when they come with that active bleeding, they may or may not come off the OCPs
Right.
in a long time. So it's almost impossible to make the diagnosis. To upfront basically send the whole panel.
Mm-hmm.
It may be elevated, but at least we have some baseline to go off of. And then when we do the next one, there's a comparison. And the estrogen can raise it, and
Right.
we can see that raise, and based on the symptoms, we can make a diagnosis, or at least a high level of suspicion.
Perfect.
So I feel like if they're not being sent at baseline, then we're at a loss, because we can't just take them off OCPs to make the diagnosis.
Correct. No, and you're right.
So
Absolutely.
just send the whole panel up front. The antigen antibody, the Diphasic antibody, the factor VIII will be elevated. There's no
Yes.
question about it. So just that
Okay.
helps.
Cool. And that's on that form too. We developed it with HEMONC, that whole form too. So that what I said, what's going around or what's been sent out was developed with the hematology team as well. We have their approval on board with it. Any other questions or concerns?
What's your opinion about Skyla versus Mirena?
Skyla is much lower amounts of progesterone. It's versus the Mirena. I will use it in a girl who has a smaller uterus because it doesn't have a uterine size limitation, where the Mirena, they have to sound to 6 centimeters. The Skyla can be put in a smaller uterus. Also in girls who have really severe acne, I have had girls who get a Mirena who the progesterone, although it's lower, is systemic enough to cause that worsening of the acne. So there are some girls who I will use a Skyla, and also I've had some girls who've had pseudotumor, and I tend to use the least amount of hormones possible. So I'll use a Skyla in those girls, or a Kylena, which is 5 years instead of in the same size as the Skyla. Anything else? All right. And thank you all for all your help caring for these girls.